Welcome to the Wellness on Tap podcast with your host, Dr. Debs Eastwood.
So what is it about the gut then that fascinated you, this supposed gut-brain connection? And
well, it's always been interesting. Have we started already? Oh, okay. It's always been interesting because as medics, obviously, like we look at physiology, and when the physiology is abnormal, we know exactly what's going on, what to do. But when there is some abnormality, then it normalizes, and there's still the same issues ongoing. It makes you wonder what exactly is going on. And it's that mind-body connection that it's happening.
that traditional medicine, and as a medic myself, I will say this, that doesn't see, in my experience.
Yeah. It's, as I say, we're trained to look at physiology. We're not trained to do psychology in clinic. And I think that's where the problems are, because we have limited time. There's someone that's complicated, that has really complex disease, even though there's no structural problem like the IBS, but it's just affecting them so much. And we just ignore the psychology, and there's no treatment available. Well, there are some centers that offer treatment, but as you know, the NHS with the waiting list and everything, it's just, you just feel like you're abandoning people in their worst need.
Yeah, which is not a happy place to be, is it? For
No.
us or the patients.
No, and it's that where I started struggling a little bit with looking at, you're abandoning people in letting them struggle on their own. And even if you discharge them to their GPs, the GPs have even less time. Yeah. So you just leave people suffering without any way out. And it's just overwhelming, I think, now as well, with a lot of information that's out. And, if you go on the internet, you'll see 5 things to do about this and 3 things to do about this. And how many of those things are really evidence-based or someone knows what they're talking about? It's just, it can be hard.
And that you've just said was exactly my problem when my little brother was ill.
Yeah.
And he was getting the treatment that he needed for the disease state that he was in, but none of the rest of him was being looked at. And that was when I started looking, and that was what I could see. Yeah. And I'm like, so which of these is any good? I don't know. I haven't got a clue, then about energy medicine, about, chakras, I didn't know anything. And I'm like, so how do I know that this is going to work and that the person doing it is any good?
Yeah.
So I hear exactly what you're saying. It's so right, isn't it?
Yeah. And it's, for IBS, there's a lot of evidence behind it. It's not, woohoo science or anything like that. There's a lot about hypnotherapy, cognitive behavioral therapy, and mindfulness. And I think it should be more of a personalised care. And this is, again, where we struggle in the NHS, is that we don't personalise the care to the need of someone. And also for complex diseases that have complex biopsychosocial model, it should be an MDT, multidisciplinary involvement. And we can't offer that. And it's very fragmented care that people get, and it's not right. But I don't know what the alternative is, but I just decided, I needed to try this out and see whether I can help in a different way.
So what is it that you offer?
So I offer personalised online cognitive behavioral hypnotherapy. So I combine cognitive behavior techniques and gut-directed hypnotherapy and mindfulness to treat someone that has IBS.
So what sort of typical patient do you get coming to you, if you do get a typical patient?
So, IBS can present different ways. And this is what's fascinating, that people have different behaviors that maintain the problem, or different anxieties related to the problem. So you might have someone that has severe anxiety about toilets, toilet access. So if they have, IBS and they're going to go traveling somewhere, toilet is on their mind constantly. What happens if I do this? So it's that is a very common problem, the toilet access, and you see it quite a lot. Or the other aspect will be is affecting their work. And luckily, a lot of people can work from home, but when they are forced to go back into the office, there's another problem that they have to deal with. And yeah, commuting to work, trains. I mean, how many times have you been on a train and have you used a toilet on a train?
I try not to.
Exactly. What if you were desperate and you had to, like, you know, it's we're not equipped, and it's sad. Yeah.
I agree. So you started out as I did,
Yeah.
going to medical school,
Yep.
deciding on your specialty. Did you go into general medicine?
Yeah. So obviously you can go straight into gastro. So I had a very extended medical journey. So I started in the UK. So I did. So it seems like my life goes in cycles of nine years.
Okay, how interesting.
Yeah, I don't know why, but so I did like 2 cycles in the beginning when I was in Cyprus. I came to the UK for 9 years, then moved to New Zealand for 9 years, and then came back here. It's been 9 years now and it's renewed, so who knows? But yeah, I started. You can't go straight into it, so I started in the UK. Did the exams and then went to New Zealand, but New Zealand wouldn't accredit those exams. So then I had to do those exams. And then I came back to the UK to do a little bit more training, specialized training. And then I decided to stay, but they wouldn't accredit the training in New Zealand. So I had to do again some things here. So I ended up taking the long route, but
Fully exammed out by the sounds of things.
Yeah. 3 professional exams.
Oh,
Yeah.
that's shocking. So med school here in the UK.
Yep.
And then initial training, so like your house officer jobs and that.
Yeah,
here?
and until the MRCP. And it was, I think, the time they were changing the training. I don't know, with the numbers. Do you
That
remember?
wouldn't surprise me.
Yeah. So no one knew what was going to happen. And at the time, I think I met a lot of people that came from Australia to do like a year here or there. And they were saying, come to Australia, come to New Zealand. Blah, blah. So I thought, why not? So
Yeah.
I did that.
What does the MRCP stand for? I can't remember
So
now.
it's the Royal College of Physicians, the exam that
That's
you have
right.
to do.
Yeah, that's right. Yeah.
Yeah.
And it's a real rite of passage, isn't it? That
Yeah.
the doors are closed until you've got that to any higher training.
Yeah, and it's
basically,
the same
aren't they?
I think for the surgeons, the MRCS. So
Yeah, that's right.
Yeah.
So, and for anaesthetists, it's the Royal College exams again as well.
Yeah.
So the cluster are called the primary, and you can't go any higher on
Yeah.
to do your finals until you've passed the 2/3 exams, depends how you want to define it, that make up the primary. So it's all very similar, isn't it?
Yeah. The training is more or less the same, and even the college in New Zealand is Royal Australasian College. So I don't understand why they're not joined into their training and accredit each other, but
And they don't.
no.
Oh my goodness. So you were here in the UK. Which med school did you study at?
I was at UCL and Royal Free.
Okay. Yeah. Central London.
Yeah.
Yeah. Okay. So both of which I've been to, funnily enough, both with my brother.
Oh, okay, yeah.
He was in University College for 6 weeks and then a week in Royal Free. How bizarre is that?
I know. It's a small world.
Yeah. So I know exactly where they are. And then
New Zealand.
So which part? Because I've been to New Zealand. I love talking about New Zealand.
I started rural. So I did Rotorua for 1.5 years. And then went to Wellington for 5.5 years or 6 years. And then did 6 months in Hamilton and 6 months in Auckland. And then back to Wellington and then left.
Wow.
Yeah.
Only place out of those I haven't visited is Hamilton.
Yeah. It's a very farmers sort of area. Yeah. There's a lot of farming in there.
Very rural.
Yeah.
Yeah. Yeah. I flew into Auckland with nowhere to stay because I'd heard about all the backpacking lodges and just asked them at the desk when I got in. I said, how do I get somewhere to stay here then? Because this was pre-internet, pre-mobile phone sort of time. And He says, oh, just go out the door and turn right. There'll be loads of people. They'll be fighting over you. And that's the way it was. It was great.
Yeah.
But that was pre-medicine for me. So how different did you find it?
There's more or less the same systems. I think New Zealand is like the NHS. The only, I think, difference they have is that people have pay for to go and see their GP, which is a bit odd. But other than that, but they are very strict with funding. When I was there and had a lot of inflammatory bowel disease patients, there was a lot of issues with getting access to drugs that are being used in Europe and things like that, because there's a lot of restrictions because they're expensive. But apart from that, the training there is amazing. I've learned a lot.
It's a lovely place, isn't it? Really quite a sleepy place overall in comparison to the UK.
Yeah, yeah. But it's different because, when you're raised in Europe, there's some elements that you miss. So, you can do traveling, but apart from, everything is quite far away in New Zealand. So you can't do a weekend in, Italy or something,
No.
Yeah, whereas here you can, get on a plane and do whatever you want to do. But there is a little bit isolating, I think.
Yeah, I completely agree with that. I mean, the only reason I really went there is because I was staying with my cousin who lives in Sydney.
Yeah.
And I just thought, relatively speaking, this is next door. It's like you just exactly said, it's like getting on a plane and going to Italy. And I thought it'd be really stupid not to go while I'm here.
Yeah.
So, yeah, I did. So what made you want to go into gastro then?
I think as you train in medicine, you're influenced by a lot of people that you work with. And I did have great sort of models that, like consultants I worked for that I liked. And they were gastroenterologists, but also was always fascinated because it's such a huge area, gastroenterology, where you can subspecialize as well. So, I don't want to insult any of the other specialties, but, cardiology is the heart and the vessels around it and, the rhythm stuff. But gastroenterology is huge.
That's true. Yeah, you'd not thought about it like that. I mean, everybody thinks anaesthetics is quite niche and you're just in theatre putting people to sleep. But it's not. It's much more than that.
Yeah.
But people looking at gastro might also have that same mindset.
Yeah. So
what sort of different areas can you study within gastroenterology?
So I was more interested in what we call luminal. Anything inside the small bowel, large bowel, not the liver or pancreas, because that is different procedures that you have to do. More complex things there. And then I had a more specialist interest in inflammatory bowel disease, so Crohn's and ulcerative colitis. When I came back to the UK, I did a little bit of research there. And that was the plan, to do research and eventually go back to New Zealand and do more there. But I decided to stay. So,
And let's see. So you're just starting on a second 9-year cycle potentially, if the pattern
we shall see where that goes.
follows through. Yeah. Time will tell with that one, won't it? But so looking forwards then, you are currently helping and hoping to do more, helping people outside the traditional structure of the NHS.
That's the plan. Obviously, I'm taking time off to do this, so we'll see how it develops. But that's the plan. The plan is to provide an online platform for IBS patients offering these services.
Will the NHS refer them on to you, or?
I don't think they can directly, because obviously it's a paid service, so it's like private, but I'm not providing private medicine. So it's hard to know. And I don't think a lot of GPs and they're up to date with the developments that are happening. So I'm in conversations with possibly doing some webinars to educate them. Because, there's a lot of the psychological treatments that people just dismiss or they're not aware that they exist. And there's not a lot of people that offer them. That's the other problem in the NHS. So even if you wanted to refer someone to the NHS, there's only a few centres that can do that. And it's hard. But it is that struggle between coming off from a free service to offering something that's paid. But, it's there's a lot of doctors that do private medicine, so I don't see what the difference is. But, yeah.
And what interests me is that a lot of the doctors that do private medicine, not all of them, but a lot of them are surgeons. And so you're going directly back into the same structure, but paid. So you're getting the same as you would in the NHS.
Yeah.
But you're paying for it instead of it being for free. Whereas what you're offering, the sort of things I'm offering going forwards, are completely outside of that, aren't they? A world apart. But are so complementary to what's offered and can often solve problems.
Yeah. Yeah, it's, as I said, some of the centres do offer it. I know, obviously, the gut-directed hypnotherapy is a lot of research that started from Manchester with Prof. Worrell. So they're still offering it, but because of the funding issues, because of this huge waiting lists, and I think the plan is to train more people to do it. But obviously, there's going to be a delay in that. And also, I'm not sure where the funding is going to come from for that, as we know. So, it's something that there is evidence, it does work, and people should have access to it. There are obviously the digital apps at the moment that can offer similar treatment, but it's the motivational aspect, because people sign up and sometimes they don't stick with it. Whereas if you sign up with someone to have, I'm going to have 6 sessions, you get your homework, you do that, you have to do the work,
you're more
and
present,
you're accountable for your
that's
actions.
a massive word, isn't it?
Yeah. So that's why it's important to have that aspect, I think, because you can try it do yourself with the digital apps, but the motivation and there will be days that you have a setback, or and it's nice to talk with someone that can offer you a different way out and see different ways of dealing with it and give you skills to do that.
Yeah, in other words, a human being.
Yeah.
I think in an ideal world, the service that you offer should be something that runs alongside what the NHS offers. And it shouldn't be a case of the NHS like, well, we've given you all our treatments. Like you said earlier, physiologically, you are now back to normal. But symptomatically, you're clearly not.
Yeah.
It should be then easy to say, well, this is your next step.
As I say, some of the hospitals do have the next step, but again, there are waiting lists. But there's only a few hospitals that do that. And because there's no, and the sad thing about it is that there's been a study in Australia called the Mantra study that looked at, I think it was the IBS model that they used, having a multidisciplinary team. And it showed that it was actually cost effective having all the disciplines in one center and helping these people, because once you provided all the treatment that's necessary, people stop going to their GPs, and you treat the person as a person, and that's the end of it.
Because when you've got people wandering around struggling, they're not going to go to work, are they?
No. So IBS actually is the second, I think, cause of absenteeism and presenteeism. Yeah. I think probably things might have changed now that people work from home. But it is, and it costs millions.
Yeah.
Millions.
Yeah.
But, and that, I did a post once about, how much it costs and stuff. And people don't take that into account.
No, which, the economy of the country should take that into account, shouldn't it? It should look at everything and say, well, actually, if we spend a bit of money here, we're saving so much over there.
Yeah. But it doesn't work like that, does
No, it doesn't, does it? This is me with my ideal world head on.
We both know that it doesn't work like that.
Yeah. But wouldn't it be nice if it did?
Yeah. I mean, we know the models, we know what needs doing. It's just we're not doing it, and don't know what needs to happen for something, to provide this sort of care. It's
Yeah, because I mean, when you look back, like centuries before we had medicine as we have today, people would have been looking to these more natural treatments, whether that have been, the herbs that they found around them or, whatever. That was the norm, wasn't it?
Well, yeah, but then obviously we started doing the studies and everything, so then we started accumulating evidence for stuff. But I think there's a lot of things that are being developed, like there's a lot of, obviously in gut health, there's a lot about the microbiome and all that, but I don't think we have the information yet to know how to process all these new developments that are coming through and what to say to people, because it's overwhelming for doctors to understand what's going on, let alone what do you explain to people, because obviously we don't have the standardized tests or anything like that. So yeah. But yeah, developments are happening all the time.
Which is good, isn't it? When you hear a lot more about microbiome these days, or maybe it's like, you buy a new car and it's a red Mini, so you see red Minis everywhere.
Yeah.
I don't know, but I certainly have found, for me, it's a word that's becoming more and more apparent. What's your take on the microbiome?
It is, but as I say, it's I think there's a lot of interesting studies and interesting data that are coming out about being the cause of a lot of diseases, and what we call about the microbiome is obviously the bacteria in your gut, and we all have them, and when is unbalanced, so it's a dysbiosis because you have good bacteria and bad bacteria. So yeah, when you have the dysbiosis, which is an imbalance of I think more the bad than the good, then there's some disease models that have shown that is related to that. And IBS does have part of that, but again, we don't know exactly. It is so many bacteria, so many different pathways, and there's diets in every country is different, additives are different, so there's a lot of things that affect it, and we haven't standardized it yet. So, but yeah, there's a lot of evidence coming through.
Do you think modern diets have a lot to play in IBS?
I do. So diet is a huge issue with IBS in the sense that, yes, it can play a part, and it can. Some people have food-related triggers. However, this is where the other problem happens in IBS is we have lack of dietitians that are trained in a specific model, which is the low FODMAP diet, which is a specific diet that's been proven to help with IBS.
Okay.
So it's FODMAPs are, I'm not going to go through what exactly, it's a fermented oligomonodisaccharide. Anyway, it's a polyols. So it's a long, they're different.
Oh, is it a big long acronym?
Yeah, it's the individual acronyms, but so it's basically carbohydrates that exist in fruit, in milk, in your what do you call it, the sugar substitutes. There's some of them that we do know that are metabolized in the gut differently. So what they do is they produce a lot of secretions, they produce a lot of gas, and so IBS, a lot of the patients have problems with visceral sensitivity, so they're sensitive to the stretch of the gut. So that is sensed as pain. So these carbohydrates cause the gut to stretch or cause the gut to move faster or slower. So with people with IBS, that can exacerbate the symptoms. So this diet, which is basically, it starts with an elimination. So you eliminate all this. Then you slowly start to reintroduce them to figure out which ones are causing the problem. And this should be done with a dietitian that's trained in to do this diet. But this is where the other problem arises. So these days, what happens is GPs tell the patients, go and look it up. So people go and look up what are these carbohydrates and all that. So they end up doing the restrictive phase, but they never do the reintroduction phase.
To see, is that to see which one it is, if any, that's...
So they end up restricting. So there's some people with IBS that will end up eating chicken and rice forever, thinking that is, and then they develop what we call food fears because, the idea of trying something that might trigger symptoms is causing problems. So that's why I'm saying diets are a little bit, and also with IBS, there's a little bit of, some of the patients have perfectionism as well, which can exacerbate things as well. So so the diet is an aspect where, yes, it plays a role, but it's an interesting topic, I think, and we know a few things that definitely can trigger IBS with food, but it's something that people should do with a dietitian, not try and do it themselves.
Yeah. I know somebody who had got ulcerative colitis and suffered with it a lot, and one of the things they were very comfortable eating, and the GP even said to them was a really good thing, was chips. And they tried that and it fell true for them, and potatoes were, were very, very good for this particular individual. And I'm sure it's not the same for everybody. And I'm sure some people it would be really bad.
Yeah, and this is it, that there's no one size fits all. Yeah.
So you mentioned a couple of things there that made me think, mind-body connection, gut-body connection, gut-brain connection, because you mentioned about food fears. So what's your stance on that?
So, IBS is a disorder of the gut-brain interaction. That is the definition of it. And this was reclassified in 2016. So before that, obviously, there was a lot of stigma. There was a lot of people felt dismissed because, all the tests. So there's no structural problem. It's the function of the gut that is not great. And we do now know that it's the nerve, they are connected, and they are always connected from development. So they develop from the same structure, and they are connected with the vagus nerve as well. So the way I describe what exactly happens in IBS in simple terms is, if you have the plumbing system, you have the alarm system, and you have the sensing system. So the plumbing is your gut. The alarm system is your autonomic nervous system, which is the vagus nerve. And the sensing system is your brain. So what happens in IBS, at some point in your life, you might have had a plumbing issue, which resets your alarm to be on high alert constantly. And then your sensors is constantly going off as well. So basically, anything that happens in the gut stimulates the alarm, and then that it ends up going like in a big vicious circle. So that's a simple way of explaining it. But
we like simple ways of explaining it, especially with things that are really graphic.
Yeah.
I mean, I know not everybody can see pictures. People with aphantasia can't do that, but nonetheless, we've all physically seen plumbing.
Or the other way I'd describe it is, if you have, let's say, two friends, that one is a little bit emotional, one of them is very paranoid in a way, and there's an alarm that goes on constantly. The paranoid person is just going to constantly stress the emotional person, and then they can feed off each other. So that's, again, how to describe it probably.
And the work that you do is aimed more at calming the brain.
So it's calming the dysregulation and also addressing the thinking. So with hypnotherapy, what you can do is, bring back the regulation system to what it was. And also with cognitive behavior therapy, you target the thinking, the behaviors, we talked about food fears, you can target that way. Yeah. So
stop people being perfectionists. if that's their thing.
You can't, but you can explain what perfectionism does and how that is perpetuating things. It's not 100% what's causing it, but it's part of sometimes what perpetuates things. Yeah.
Yeah, it's acting as a trigger.
Yeah. Not a trigger, like it's in the background that it's an influencer, let's say. So
I like that. Yeah. So there's lots of different things.
Yeah, it's as I say, it's a biopsychosocial disease. Like even with chronic pain, I'm sure there's a lot of things. It's not just the pain it's people's perception to pain, how they sense the pain, what emotion they're attached to the pain, what the pain does to them, and two people can have the same pain and react a different way.
Yeah, totally.
Yeah, and it's exactly where the different treatments help in different ways. Yeah,
I would agree with that. I mean, I got myself trained for clinical hypnotherapy just in a smallish course, not one of these big long. I don't know what you did. I'll have to ask you in a minute. Yeah. But in recovery, I remember there was somebody who was really struggling after foot surgery, and they'd tried everything. They'd gone through all the recovery pain-killing drugs, and nothing was really working. And I went in and asked, I says, what did your pain actually, what's it feel like? Describe it to me. My foot is on fire. It's hot. So I says, are you willing to go with me here? I says, this is not a traditional, I'm not going to give you some more drugs. You got to go with me. Said, yeah, anything. They're the perfect people, aren't they, to hypnotise? And I just got them to imagine a bucket of really cold water and to dangle the foot into this bucket of cold water. And you could almost, they didn't say anything, but you could see on their face that they were going,
Yeah.
And within half an hour, they were discharged to the ward, relatively pain-free. This is great. People were looking at me going, what are you doing? I said,
It's what the Stoics always say as well, is like we suffer more in imagination. And this is what hypnotherapy does, is imagination therapy in a way. It's not woohoo, it's evidence-based, but you're more susceptible to positive outcomes. And obviously, if you have a positive outlook on things, it works better. But yeah.
So did you take yourself away from medicine and train in clinical hypnotherapy?
Yeah, I did. So I did a diploma in cognitive behavior hypnotherapy through the UK College of Hypnosis and Hypnotherapy, which is great. I did it all online. You do have to, it's like quite regimented. You have to have online sessions, supervision, blah, blah, blah. And I enjoyed it so much. And it doesn't teach you the gut-directed things, which I did more training after that. But I found it very, very fascinating. Yeah.
So that was your basic introduction.
Yeah.
And you went on and did the gut stuff, because obviously that's the field you were working in.
Yeah.
Was it difficult to learn the clinical hypnotherapy when it wasn't about the gut, or were you?
I think it's more like it's a concept. So it's just, hypnotherapy has the same structure, right? So you have the induction, the deepener, then you have, with the deepener, there's a relaxation part, and then you have the suggestions, you can have then the emergence, and then you can have post-hypnotic suggestions. So, I think once you've learned the structure of it, it's easy to then, what we use in hypnotherapy for suggestions is metaphors. So, let's say a common metaphor that people use is that, if your gut is not functioning well, that it's like a stream, and then you can either slow it down or, so you can do a little bit of that. But it helps first to have someone that's calm, and that's where you teach people how to relax, because we're all stressed, and the stress perpetuates things. And that's what I don't usually start with hypnotherapy. I usually start with teaching people relaxation just with breathing. Also there's the progressive muscle relaxation or imagery. So then you build from that. And some people have fantastic results with just the relaxation, because it addresses the stress if that's what's maintaining things, because that's the part of that autonomic dysregulation part of it. And sometimes that's all it takes. But in others, obviously, if it's 20 years of this problem that they had, you have to combine the hypnotherapy as well.
Yeah, it's like they need a bit more, something a bit stronger, if you like.
Yeah. And what they say at the college is that all hypnosis is self-hypnosis. Like you do it every day to yourself negatively. Like, you know, the way you talk to yourself. We do that all the day, all the time.
We do. I know when I did my training, they said, how many times have you, you know, got in your car and driven somewhere when it's a routine journey and you don't remember anything about the journey?
Yeah.
You are effectively under a form of hypnosis while you're doing it, because your mind's not there, you're thinking other things.
Where you're focused on something, but then you're susceptible on, you know, what happens. It's like reading a good book as well. So you focus on what was going on in front of you, but then, you know, it's things that happen behind your brain, all that stuff.
Yeah. So do you think, sort of jumping back to the diet again, because we mentioned inflammation and its role in that before. I mean, a lot of the stuff that gets packaged onto us as food, which has minimal nutritional value and is highly processed and comes from nutrient deficient soil and causes inflammation. Do you think that has something to do with it? Are we better off?
Yeah. I think, as I say, there's a lot of research going into it, but there is, I think I did recently an online webinar of, it was a microbiome, and they were talking, there's a dietary psychiatry part at the moment that is being developed because, it's looking at how the diet can influence your mood, sort of thing. And it's because of the gut-brain interaction. As I say, in the next few years, there'll be a lot of developments. But at the moment, I think there's a lot of things coming out, but it's like little puzzles that we don't know how to piece them all together and say, this is the model for this is the model for that. There's a lot of information.
There's a lot of information, isn't there? And it's responsible not only for IBS, but a lot of our other disease processes within our body.
And we have to be careful because there's, you know, it can overwhelm people. They can get the wrong information. Okay. And, you know, some people package things that, you know, it's not very evidence-based. And I think at the moment, yes, we have to acknowledge the placebo effect as well a lot of the times. But yes, I think evidence is good. And I trained with evidence-based. I always look into the evidence first.
Yeah. And I'm exactly the same, like being a scientist first, then a medic afterwards. Anything that I endorse, you know, like the molecular hydrogen water, they have about 1,500 research papers behind them. You know, therefore, I can access those, I can look at those, I can make my own assumptions based upon that. Yeah. But I also know that there just is backing. It's not just somebody who's decided, yes, this is great.
Yeah.
Because we don't want that, do we?
No, as I say, and there's a lot of information out there, and, you know, it can overwhelm people, especially if you're someone that's struggling and you're looking for an easy way out. You can end up spending money on things that are not, not helpful.
Yeah, we've got to protect the vulnerable people out there, haven't we, by giving the correct information.
Yeah.
So your 9-year cycle then, so you've got 8 years of it left to go.
Yeah.
Or ish. Where do you think you might be? Not just geographically, really, but, you know, in terms of the work that you're doing?
I guess depends on opportunities that come along as well. So I'm open-minded. You know, I've started this, don't know where this is going to take me, but hoping I have ideas. I have ideas of developing it further and educating. I do want to offer free stuff as well, but obviously to start with, because somehow I have to make a living.
Absolutely, yeah.
I have to start with what I can earn. And then once I know that I can easily produce that, I can probably create something, thinking of a course maybe, or something that will help people.
What do you think about our younger generation, the kiddies? Do you think they need educating?
You mean as patients or as doctors or
as just members of society in more of a preventative role?
Yeah, I think we're really bad. I grew up in the Mediterranean where food was, you enjoyed food. It was like a tradition, like even the cooking of it, like you would learn things. It was the produce. It was all about, it was a culture that, food is great, Looking now, how do we, like our relationship with food is weird. And a lot of families are just not even sitting together to eat. It's, takeaways. So we don't really teach people how to enjoy food. And I think that was actually quite striking what Jamie Oliver, I don't know if you've seen when he went to America, where he started crying when he was he was trying to teach people he went to schools and tried to teach the cooks there how to, use produce and things like that. Children there didn't even know what a broccoli is. Like and they were really obstructive and really, so he got really frustrated. But yeah, that was shocking to see that, their relationship with food, how from early age on, we don't know what a broccoli is.
I can't even imagine not knowing some of the more exotic things that are only recently coming across to the UK.
Yeah.
Hopefully I can be forgiven for not knowing what they are, but things that are around us all day, every day.
But the other thing also is the cost of food as well. Like it's easier to feed a family of, 5, 6 going to McDonald's than it is to go and buy the vegetables and cook. It takes a lot of effort. So I think from that aspect, I think we do need to educate. But it is, again, an economy issue, and it's
crazy, isn't it? Because, going back, almost 100 years now, sort of around, the war issues where food was rationed.
Yeah.
And people, I'm not suggesting that was a good thing, by the way, it was a necessary thing, but in terms of nutrition, people were healthier from a nutritional perspective then because they were eating natural produce from soil that wasn't depleted because it wasn't over-farmed, because a lot of people were growing their own where they could, wouldn't they? Mm. And so everybody knew then. So what's happened? Where have we lost that?
Don't know.
It's a big question, isn't it?
It was a quick fix, then don't know. It's tragic though. It's because you say the kiddies are just. It's not just that, but it's also the attention. Like a lot of kids. How many times have you seen like people in families having a proper conversation? It's all about the phone. It's all about So it's interesting because I think both of us probably have gone through the most technology development in our years. So I think like I started with, we only had one channel on TV. So you had to plan exactly what you wanted to watch at the specific time. Then obviously it was more channels. Then it was the internet, which was a dial-up.
Yeah, I remember that. Funny noise, yeah.
And then suddenly it's just gone, AI. So we've gone through all that, and it's nice to see how things have developed. But what about the kids that have started with all that in front of them? I don't know how that's going to develop even more. I don't know.
And I think it goes, which is funny, isn't it? Because all of these things are supposed to make life easier and give us more time and make things simpler. And yet we seem to have less time and are more stressed. So therefore, being able to do the more traditional things like you grew up with, growing up in a family where, making proper food is a daily occurrence. It's way things, it's life.
Yeah, yeah.
And that's where the education of the kids really happens, isn't it?
Yeah.
You know, I'm sure you can cook because of what you...
Yeah, I love cooking. And this is, again, another thing that I always try and relate that to my patients. Like, I love food and I love cooking. And it's just, I would, if I couldn't eat what I wanted to, obviously I do have foods that upset me and things. But yeah, if I was in their position and having to leave off 2 things, and I would, I don't know how they do it.
No.
And that's why I want to help. Like, yeah.
Yeah. Yeah. I went about a week without having any carbs, and there was a group of us out for a meal on the very last day that I was supposed to be sticking to it. And I'd scoured the menu, and I ended up having a crab burger. And I said, please don't bring it in bread. You know, can you wrap it in lettuce or something like that, or do something different with it, but don't bring me the bread. And they brought it with this big pile of chips. Oh, I have to say they were the best chips I'd had in a while. I only had a few. I was very good. Well, I wasn't. I was goodish. But
Yeah.
So for those people that, you know, and that wasn't because of gut issues, that was because of me just wanting to be a bit healthier, lose a bit of weight, that kind of thing. So for people that have to do that all the time.
Yeah. Or you can't go out in a restaurant because, you know, you're scared of if you eat something, what's going to happen. Or, or what people will think if you go to the toilet, or, you know, there's a lot of, the quality of life of people with IBS has been looked at studies, and the shocking fact that I found was one of them showed that is equivalent to end-stage renal failure patients. You know, the people that go on dialysis 3 times a day because of the restrictions, because of the isolation, because of the shame, because, you know, it's not a nice, and I don't know why. Well, I do, you know, bowel issues come with a lot of shame, embarrassment, and isolation. And yeah, partly we all know why, but
yeah, because if it goes wrong, it's very public and embarrassing, isn't it, potentially?
Yeah, but can you imagine having that for 20 years?
No, thank you. I wouldn't wish that on
You know,
anybody.
it's, we all have, everyone probably can relate, because obviously, you know, if you have a bad gastroenteritis 1 or 2 days, but that day, you know that it affected you significantly. But if you had that for 20 years, how is that, you know, you can't have a relationship.
No. When you put it like that, it becomes very obvious as to how it would affect your quality of life.
Yeah.
But that's a shocking statistic in that it's...
But this is where we make fun of, you know, people that have bowel problems sometimes. But we don't understand that that's, you know, it's like the iceberg, like what you see and what your perception is about them is you see someone that's flaky or cancels last minute or doesn't want to socialize, but actually deep down is, you know, all these fears they have that, you know, and how restricted they are by their disease. And it's just not really, we need to be more kind and less judgmental and try and see, like, put yourself in their shoes in a way.
Yeah, absolutely.
But a lot of the time they won't even tell people because they're afraid of that judgment as well. So
yeah, we just need to be kinder.
Yeah, we do.
Well, thank you. I've really enjoyed this chat.
Yeah.
And I hope that you do go on to do more.
Thank you. Yes, I hope it works out.
Yeah. Let's educate the world, eh? Take away the stigma.
Yeah, I think we have to. It's we're not good at that. And I think, people should not suffer in silence.
Yeah. Well, thank you. I look forward to seeing where this goes.
Excellent. Yeah, me too.
Yeah, all the best, my lovely.
Thank you.